Welcome to this session of Masterclass number 102. So as we are moving up the ladder in terms of complexity of dealing with the fertility cases. So today's topic is what do we counsel and how do we deal with a euploid embryo failure in an IVF. So implantation is a complex process, everybody knows, and majority of it is driven by the embryo. But when we have tested the embryo and when we have found it to be euploid, so we assume that, yes, I mean, we have done our best, but then when it fails, then we are back to square one, especially with the patients, where our focus shifts from the genetics of the embryo to the uterine factors, the endometrial factors, the technique as to how we have transferred the freezing thawing technique and difficulties during the embryo biopsy, and also about the hormonal factors, immunological factors. So here we are focusing more on the features other than the biopsy part or the PGT-a part, so that we can counsel the patient so that they are convinced not to change the IVF center, but we should try and explain so that the patient retention can happen, and also we give our best to the patient in terms of the success. So we will be dealing only with the practical points and we will not be talking about the theoretical aspects of it. So Dr. Jay, you can take over.
So, friends, remember one thing. First of all, it is not very common in India across IVF centers to do PGT-a testing very routinely. That is the first thing. Okay, majority of the times, what happens in India, if you are a doctor or a patient, you know that if your one IVF cycle has failed, the next IVF cycle is going to be a donor cycle. Correct? I personally think these days getting a donor for people who are doing the donor program is getting exceedingly tough, is what I have heard from people, unless you are forging documents. That's a different story. Now remember one thing. This lecture is only going to benefit you if you are wanting to practice self cycles. If in case you are somebody who is any which ways, putting up a face and then doing donor from behind, all these things are really not going to benefit you in any manner. So there is no role of joining this session from there onwards. What I'm going to be trying and explaining is basically why a euploid embryo fails. So when you have to face the patient and answer, okay, this could be the reasons why why something like this happens, you give a straightforward answer to the patient and hopefully patient has a take home message to carry home. So I'm switching to the I'm basically switching to the screen share, and I am hoping that the screen sharing is going to be visible. Shilpa madam, if you can just verify that.
Yeah.
Fine. So this is very, very simple, guys. Just remember, this is going to be the oocyte, polar body I drew there, and then there is going to be a sperm. Okay, this sperm is going to be immobilized, basically straight tail, and it is going to be injected inside the oocyte, which is then going to fertilize. And once the fertilization process begins, the embryo begins to divide into a two-cell embryo. From the two-cell embryo, the embryo begins to basically go into an eight-cell embryo. Okay, of course, there will be a four-cell stage in between, but this eight cell is very important because somewhere between the journey from six cells to the journey of morula, okay, there is going to be something called as genomic shift, and this genomic shift is going to allow the embryo to form this guy. It is going to allow the embryo to basically form its own DNA, right? And that is the DNA which you are going to be testing when you have a blastocyst lying down in front of you. Of course, for a country like India, you do not even have techniques to standardize PGT-a, nor do we have techniques to standardize non-invasive chromosomal studies or PGT-a. So because we do not have any of these techniques available, currently what is preferred is somewhere where your laboratory is, but for a broad spectrum, we would like to do PGT-a provided expertise is available. Take a few cells and study if the embryo is genetically euploid or if the embryo is basically aneuploid or it is somewhere in between, which is mosaic, right? Now, one thing is very, very clear. Okay, all the guidelines are always going to recommend that this is the embryo whom you are supposed to transfer, that is the euploid embryo. Do not end up transferring any other embryo otherwise in a situation where you cannot explain it to the patient. The reason for that is very simple. If I draw the uterus here, uterus will have an endometrium, and when the embryo enters inside the endometrium, in the endometrium there is going to be something called as a embryo to endometrium talk. Okay. This embryo to endometrium cross talk, no, is more like husband and wife talk. See, in husband and wife talk, you are 100% certain that the wife will win. Okay. There is no question in that. But in embryo and endometrium cross talk, this is the only talk where the husband and wife are interacting, but you do not know who will win. Because sometimes the embryo can be abnormal, the endometrium can still accept it, then the endometrium realizes अरे गलती हो गया, and the patient can have an abortion. Sometimes the embryo can be sometimes the embryo can be normal, but the endometrium can be abnormal in cases of patients who are having thin endometrium, who are having fibroids, in patients who are having endometriosis, in patients who are having adenomyosis, and it can still give rise to an abortion. In fact, that is the basis for doing reproductive immunology, right? You need to have a clean pelvis. Reproductive immunology works the best when you have a normal pelvis. It does not work when you have grade 4 endometriosis and like a stupid you will go ahead and do LIT. Correct? In that situations it will not work. In fact, the greatest benefit which has happened in India, especially by fertility consultants, is because every fertility consultant now is a practicing immunologist. Because of that, they have added so much complication to their fertility practice that people like us who are doing second opinions for fertility practice, our practice has shot up like anything, because everybody looks at a 17.5 cent. I had a patient today actually, 17.5 centimeter subserous fibroid. Okay. And she has done only 5 IVF cycles. I wonder why an abdominal palpation was not done. Okay. In a situation like this in 5 IVF cycles, of course, we counseled her to undergo a myomectomy, to which she was absolutely shocked that how on earth can you tell me to undergo a myomectomy for a fibroid which is only 17 centimeters in size? It is good only that God does not make such people pregnant. So if in case you look at the otherwise situation, this entire thing when we try to study, we are trying to tell you that when the embryo is euploid, that means its genes are normal. Okay. But the manner in which these genes are getting expressed, okay, are they getting expressed on time? Okay. For example, when the embryo reaches the endometrium, you need certain genes for adhesion, you need certain genes for angiogenesis, and you need certain genes for the invasion. Okay. All of this is called as what we know as a implantation science. Correct? No? We do not exactly know at what time the embryo should express what genes. So if in case we want to study that, we need to add one more complication to our life, and that is called transcriptomics. Okay. Transcriptomics means we are still studying. Transcriptomics means studying the transcript. Studying the transcript means studying the DNA as well as studying the RNA expression. Okay. Currently, it is only into research laboratory settings. But if there is something which we are going to be looking forward to in the next 5 years, then it is development of this, because in the next 5 years, I foresee and I almost predict that majority of the people who are undergoing an IVF will undergo an IVF for a chromosomally normal embryo, euploid embryo. And when the patient is undergoing an IVF for a euploid embryo, be it the first cycle, be it the second cycle, be it whatever it is, in that particular point of situation, role of transcriptomics is going to become very important. Currently we are doing an endometrial biopsy. When you do an endometrial biopsy, you are looking at uterine natural killer cells, you are looking at BCL6, you are looking at MUM1 to rule out endometritis, and then trying to put a euploid embryo inside, thinking that the embryo and the endometrium both are normal. And then you tell the patient, don't worry, bro, success rate is going to be close to 50%. Patient is happy, you are happy for only 12 days. When the patient comes back to you, beta HCG is less than 1.2, then all of you have a blank face. Patient is going to think what went wrong. You are also going to wonder actually what went wrong, but you are not able to answer to that patient, right? If in case you were to answer to the patient that, you know what, you actually had a 7.5 centimeter endometrioma, now we will remove it. Patient will remove it, but not with you. Patient would have changed the IVF clinic by then. Okay. And this is happening very, very commonly. In fact, if you ever, I was discussing this with somebody these days. I think I've become very intelligent. So I was discussing this with somebody and I was trying to tell them that exactly if you look at the structure of fertility practice in India, what has happened in the last 3 4 years especially, the supply of fertility clinics has gone up by so much. Okay. But the demand of the patients especially the patients who are educated, has not increased at all. See, if the demand for the educated patient increases, then that educated patient will come to you and ask you for doing PGT-a first thing. They will ask you for doing biopsy hysteroscopy second thing. So in one IVF cycle, without doing any cheating, shooting and prescribing 500 luteal phase support medications, your average turnover for a single IVF cycle can go up from 2 lakhs to 4 lakhs, 5 lakh rupees just by and well informed patient. That supply has not increased. Because that supply has not increased, the problem which happens in a situation like India is that we think that we have all very few patients now, and patients are getting distributed and all, and that is going to increase and keep on increasing till we actually solve patient specific queries. And this is going to be the largest patient specific query. Euploid embryo, everything what the patient thought was done right. Still, why did it not implant? That means the patient will believe that you did something wrong despite you doing everything right. So in your counseling, you must give a strong mention to this science of transcriptomics, which is currently a developmental science. Okay. Who is doing transcriptomics in India? Nobody. Is there any research laboratory in India currently doing it? None. It is a very tough procedure to do. And remember, if transcriptomics and all these things are going to progress very nicely, then transcriptomics will require non-invasive chromosomal studies to come up in life, no matter what we try to tell. Okay, that is one. Second, very important thing I was mentioning, between 6 cells to morula, there is an embryo. The embryo develops its own genes. Correct. So your culture conditions in the laboratory have to be fabulous. That means the gene expression for that embryo in the future is going to be decided between 6 days, between that 6 cell embryo and the morula embryo. That means between 48 hours to 96 hours of culture. And that 46 hours to 96 hours of culture then becomes critically important for that embryo to make sure that the embryo does not undergo any oxidative stress, grows nicely, expresses its genes nicely, forms a blastocyst embryos, which then expresses the genes nicely, and then you transfer it in the implantation window or the best possible window of implantation, and then you get the patient around a 40% success rate, right? Probably after listening to this lecture, most of us will start thinking that, "Arey, thank God so many of my embryos implanted, you know, because if the embryos were to not implant due to any of these mistakes, okay, that means how many number of negative pregnancies all of us would have got." This also teaches us that despite knowing so many things, okay, and despite not having tested, if so many embryos have implanted, that means nature must be altering the mechanism of gene expression based on the embryo and based on the endometrium what it sees in front of it, right? That is a science which is yet to be studied, and that is the reason why so much of proteomics is coming inside the picture, where the local protein studies are being done on the endometrium as well as on the embryo, of course in a non-invasive manner. I understand this is a little hi-fi topic and it must have gone hi-fi only, but I'll be happy to answer questions. This is something which interests me a lot.
So tell me, what about the mosaicism, even if it is an euploid embryo?
Yeah. So there is no consensus between implantation and not implantation of a mosaic embryo, especially in an Indian situation. So what do? We allow patients to go ahead with an implantation of at least low mosaic embryos with a written consent and high mosaic embryos with a written consent. But the patient is also free to choose to not implant and ethically discard these embryos should they feel like discarding these embryos. There is no hard and fast rule on that.
So what about the technical aspects in taking a biopsy of that embryo and also like freezing, thawing,
It's
all these
very,
things?
very important. See, all by establishing this lecture, I'm trying to tell you that you've gone through my 100 previous master classes and you've realized that all that is very, very important. After realizing that is important, now you have reached this level that you are arguing and answering these types of questions.
Yeah.
But that's a no-brainer. You can ask Bem. She is also online. She will answer the same thing.
Hmm. So is assisted hatching
No role.
important? It has got no role. So tell me three tests that you would do as a standard for all cases who come with this PGT-a euploid embryo failures. Just three tests.
I normally do a 3D pelvis. Okay.
Okay.
To rule out if the pelvis has to be clean. That is my first thing.
Correct.
Okay. And I really do it very nicely because I think we have a good system of doing 3D pelvis. No, I means we. Okay. Vismay has a good system of doing 3D pelvis. So I think that is a very important test. See, often what gets missed out in Indian situation is sperm DNA fragmentation. And
Yes.
I quite a lot of times end up doing sperm DNA fragmentation for most of these males, even if they are trying naturally. Okay. Because it is a very important test, which I think is a very important addition in an Indian situation. Okay. Now, apart from all these things, these days I have also started to prefer to ask the patients to take a biopsy. But the problem is, no, patients these days are so confused, not total, they are confused atmas. If you tell them that you are, I had a doctor, radiologist who consulted me today. Husband, wife are radiologist. Husband has told the wife that she is having bilateral hydrosalpinx. Wife has not believed his own husband, and she has gone to somebody else, and that other another person has also told that there is bilateral hydrosalpinx, and she has done 3 IUI cycles in that. Okay, so the I think the patient quality has deteriorated much more than what the doctor's quality has deteriorated.
Yes.
Okay. And in that situation, what typically happens is, no, beyond a point in time, you just have to advise the patient and then just leave them to their fate. If in case they are going to do something, they will do something, not do something, not do something. So I recommend them to do a biopsy. 50 to 70% of them will understand and listen and get the biopsy done. The other 50% are still thinking about it, you know. So in that situation, I think these are the
Biopsy for
three.
what?
Endometrial biopsy, just in case something has been missed out, like chronic endometritis has been missed out,
So what are
silent
you
and
biopsy for? Yeah.
silent endometriosis has been missed out. Any other factor, PID has been missed out. All these things are very commonly correctable problems. Huh? Like if you look at the cervix and if you, let's say there is a gross inflammation on the cervix, first step before doing the next IVF cycle is just correct the cervix. Basically, 50% problems will be solved there only as far as implantation is concerned.
So what about anti-TPO antibodies, APLA test, ANA testing in these cases?
I don't do it in all, madam. Just in case there is an indication or just in case they have, come. By the time they come to me, all this is usually done.
Yeah.
Okay. Just in case something is abnormal, I'll do.
So what about uterine NK cell testing?
It is done as a part of the biopsy, no? UNK.
Hmm. And tell us about HLA typing. Do you routinely suggest? Because many patients now ask for HLA typing. Today I saw a patient, previous three FET failures, in that the last one euploid embryo failure. She has had two surgeries, laparoscopic cystectomies,
Yeah.
and she showed me the video. Nice peritoneal deposits are there for which nothing was done. And she
Yeah.
wants to do
Did they
a
not put a
HLA
Mirena?
typing. She wants
Okay.
to do a HLI typing and she wants to do the ERA. I said, no, I mean, just do a CA 125 and come back, and it is 60. So I said, see, your peritoneal deposits are still inflamed and they are active.
Yeah. Now
So
she'll think about it.
she will think about it. Uh, so HLA typing, you think it is overused and abused to test at this point in time when we talk about the recurrent implantation failures?
Probably. I mean, see, HLA is highly polymorphic.
Mm,
Okay. So
yeah.
whenever we are trying to match an HLA, according to me, ruling out fibroids and adenomyosis is something which is way more important than looking at HLA. Trust me, it is way more important. But then I think, see, all this is good. Probably we are not here to improve anybody's practice. Let people practice. Doing all these things only gives us a lot of second opinions, very honestly.
So when do you think we should defer the patients from going through further IVFs? Like,
Six
because
IVF cycles.
6 euploid embryo transfers?
Yeah. That is the standard of care, no? Six
Mm,
euploid embryo transfers, nothing has happened. Probably do surrogacy or then don't do anything.
mm,
See,
mm.
then there is something in the science which the science is unable to answer at the moment.
Yeah, yeah. So do you see a lot of thin endometrium in these things?
In
In
what? In
these cases where euploid embryo fails?
actually, thin endometrium has become otherwise also very common.
Yeah.
Not just in failures, not just in implantation failures. Thin endometrium is very common in IUI. Thin endometrium is very common in otherwise cycles also. God knows
Why do
why.
you think? Is it because of hyperestrogenic state of these women? But hyperestrogen should lead to thick endometrium, in
Yeah,
fact.
yeah. Tough to predict, madam. Don't know.
Okay. So this was very informative. Thank you for giving us a overview of what you think and how you manage, because we know that you see a lot of these referred cases from
So
different.
many second opinions. I mean, majority of them will not come to us for doing, at least not come to me for doing treatments, because
Their
they are
embryos will be
already,
somewhere.
embryos will be somewhere. Somebody would have just said, just take his opinion and see
Yeah,
at least what he's saying. And
yeah,
they'll have 200 questions basically.
exactly.
And most of the questions will be the same. And which
Mm.
is okay. They must be super anxious. So, we can't really comment on that. But I
What
think it is.
about going back to doing only day 3, day 2 transfers and forgetting about all this?
There are some people who are still doing day 2 and day 3 transfers. It is, you are playing a blind game, no? The
Yeah,
cases where you are winning and you are thinking everything is right. But then you are not following the standard of care, no?
correct.
You
Yeah.
if you are not following standard of care, then there is no point in then debating over all these things. See, I'll tell you what's going to happen. The future is going to be very, very AI driven,
Yes.
correct? It is not going to be intelligence driven. It is going to be data driven,
Yeah.
correct? So if the data is going to be pointing out towards a fact, no matter what shit people speak, and if the data points towards getting a surgery done, patients will ultimately get surgery done, right?
True.
They
Very
may
true.
not do it on that moment, but they will do it eventually, something like this, correct? The same thing is going to happen in fertility practice. If the data is strongly pointing towards not randomly prescribing IVIGs like how it is happening in India. See, India is one of those countries where technology adoption is much faster as compared to the technical adoption.
Mm.
Okay. So India is one of those countries where people will quickly log into Chat GPT because it is available for free and question the doctor, and most of the times they'll be right.
Correct. True. Very true. So, but thank you
So
so much. It was like very, very informative, and it was like real insight to so many things that many people probably would not deal with it on a day-to-day basis in their practice. But it was really,
no,
really
no,
good.
my only dealing with this is because of the tremendous amount of second opinions which we do.
Yes.
Huge amount. Not the
And
cycles. It doesn't convert into cycles, but the number of opinions which is unreal.